I need my video on. Hello, I'm Dr. Georges Benjamin, the Executive Director at the American Public Health Association. I want to welcome to the 14th webinar of the COVID-19 Conversation Series, brought to you by the American Public Health Association and the National Academy of Medicine. Now, today's webinar is entitled Controlling COVID-19, Surveillance, Testing, and Contact Tracing. Today's webinar has been approved for 1.5 continuing education credits for CHESS, CME, CNE, and CPH. None of the speakers has any relevant financial relationships to disclose. And please note that if you want continuing education credits, you should have registered with your first and last name. If we can go to the next slide. Everyone who wants credit must have their own registration and watch today's event in its entirety. Next slide. All the participants today will receive an email within a few days from cpd@confex.com with information on claiming credits. All online evaluations must be submitted by October 5th, 2020 to receive continuing education credit. If you have any questions or topics you'd like us to address today or in future webinars, please email us at apha@apha.org. That's apha@apha.org. Next slide. If you experience any, next slide. Next slide. And the next slide. So if you experience any technical difficulties during the webinar, please email namcovid19@nas.edu and someone will be in contact with you shortly. That's namcovid19@nas.edu and someone, of course, can contact you. Now, the webinar will be recorded and the recording and transcript will be available on covid19conversations.org. More information on the series recordings of past webinars is also available at that link. Next slide. So I'd now like to introduce to our moderator today, Dr. Karen DeSalvo. Dr. DeSalvo is the Chief Health Officer of Google Health. She is a physician leader working at the intersection of medicine, public health, and information technology, whose career has focused on improving health and eliminating disparities. She leads a team of health professionals at Google who provide clinical guidance for the development of research, products, and services. Prior to joining Google, Dr. DeSalvo was the National Coordinator for Health Information Technology and the Acting Assistant Secretary for Health at the U.S. Department of Health and Human Services in the Obama administration. During her time at HHS, Dr. DeSalvo focused on creating a more consumer-oriented, transparent, and value-based health system. Prior to that, she served as the New Orleans Health Commissioner following Hurricane Katrina. Prior to that, she was the Vice Dean for Community Affairs and Health Policy at the Tulane School of Medicine, where she was a practicing physician, educator, researcher, and leader. She serves on the Council of the National Academy of Medicine. Dr. DeSalvo, over to you.
Great, thank you, Dr. Benjamin, and welcome everybody to our webinar today. We're going to be discussing updated information about the current process and capacity of surveillance, of testing, and also of contact tracing. The focus will be on what we have learned during the course of the COVID-19 pandemic and where there have been breakthroughs and what obstacles we still have to overcome. I just want to first make a few comments before I turn it over to our esteemed panelist. Public health is what we do together to create the conditions in which everyone can be healthy. And there are many of us partnered towards that goal in promoting and protecting the public's health. I've certainly had opportunities to partner with public health, but also to be in the seat as a local health commissioner. And I have learned on this journey that really governmental public health authorities are statutorily obligated to do this work of protecting the public's health every day. It's not a special effort, it's not a choice. It's what they have to do to protect those who live, learn, work, and play in their communities. And they do this through the essential public health services. Next slide. These are shown on this slide and were actually just recently updated by the public health community last week to reflect 21st century approaches and health challenges that we all face. They broadly fall into three big categories: assessment, assurance, and policy making. All of this work grounded with an eye on equity. And on an average day, this work is no small task, but in a pandemic, it takes Herculean strength, plus a lot of stamina and resilience and passion. And so I just want to take a moment to thank all the governmental public health leaders on the front lines and all the staff who are working in health departments across this country to keep us safe. And we thank you for doing that every day with a lot of passion. Because of COVID, now a lot of people understand how important public health is and appreciate the complex work that stems from a communicable disease outbreak, whether that's about flattening the curve or keeping it flat. And of course, we know that these are critical to not only saving lives, but to giving medicine more time to stand up capacity and or to build better care models, and science more opportunities to develop countermeasures, whether those are therapeutics or vaccines. And public health has a lot of tools in their toolbox to do that work. And we're going to hear about three of those tools today that fall into the public health essential functions area of assessment, essentially to assess and monitor the population's health and investigate and diagnose health hazards and address root causes. We'll need all these tools not only up until a vaccine arrives, but also after a vaccine arrives, because this is important work that public health will have to do to minimize transmission, not only of COVID, but of other communicable diseases into the future. So I want to take a moment now to formally introduce today's presenters, who are a wonderful group to share their frontline experiences and their expertise. First, Dr. Mike Ulsterholm is going to talk about surveillance. Marty Burke will talk about their experience in testing, and Dr. LaQuandra Nesbitt will talk about contact tracing. They're each going to bring this real-world experience of what it's been like in this pandemic. Let me give you a more formal introduction of each, and then I'll turn it over to them. Dr. Mike Ulsterholm is Regents Professor McKnight Presidential Endowed Chair in Public Health and the Director of CIDREP, or the Center for Infectious Disease Research and Policy. He's also Distinguished Teaching Professor in the Division of Environmental Health Sciences at the School of Public Health, and a professor in the Technological Leadership Institute, College of Science and Engineering, and an adjunct professor in the medical school, all at the University of Minnesota. From June 2018 through May 2019, he served as a science envoy for health security on behalf of the U.S. Department of State, and he's on the Board of Regents at Luther College in Decorah, Iowa. He's also a member of the National Academy of Medicine and the Council of Foreign Relations. Professor Marty Burke is the May and V. Ling Professor for Chemical Innovation at the University of Illinois and led the SHIELD initiative on campus that has strategically deployed rapid and scalable COVID-19 testing to detect the virus for thousands of students and faculty and staff on campus twice weekly, along with frontier modeling and contact tracing efforts. He completed his undergraduate studies at Johns Hopkins University, his PhD at Harvard University. After completing an MD at Harvard Medical School, he joined the faculty in the Department of Chemistry at the University of Illinois in June of 2005. And our last panelist is Dr. LaQuandra Nesbitt, a board-certified family physician with over a decade of experience leading population health initiatives in governmental public health agencies. Dr. Nesbitt currently serves as the director of the District of Columbia Department of Health in Washington, D.C., a position she has held since January of 2015 when appointed by Mayor Muriel Bowser. As a physician leader, Dr. Nesbitt mobilizes organizations and communities to implement innovative solutions that promote health and wellness and achieve health equity. Throughout her career, she's led multi-sector collaborations to address innovation in healthcare delivery and its impact on high cost, high need, and other special populations. The integration of public health and healthcare and the impact of medical marijuana and decriminalization of medical marijuana on the public's health. Prior to her role in DC, Dr. Nesbitt served as the director of the Louisville Metro Department of Public Health and Wellness, where she led initiatives on the Affordable Care Act implementation and violence prevention. She earned her Bachelor of Science degree in biochemistry from the University of Michigan, her medical degree from Wayne State University School of Medicine, and a Master of Public Health in Healthcare Management and Policy from the Harvard School of Public Health. We will hear from each in turn and then have time for questions from you all in the audience. So just a quick reminder, if you do have questions, please send them to apha@apha.org. That's apha@apha.org. And now, Dr. Osterholm, I'll give it to you to kick things off for us.
Thank you very much, Dr. DeSalvo. It's my honor to be here. If I could have the next slide, please. Next slide. Thank you. Today, I will address for you the issue of COVID-19 surveillance and all the ramifications of what it means to our everyday public health practice. Next slide. I will be relying in large part on a document that our center put together with a number of experts from around the country on surveillance. If you look, it's part 5, the bottom one, SARS-CoV-2 infection and COVID-19 surveillance, a national framework published on July 9th of this past year. This is available on our website. You can see the address below there by going to www.cidrap.umn.edu if you'd like to obtain this document. Next slide, please. In the document, we summarize the fundamentals of surveillance for COVID-19 in their various categories. Disease surveillance, the very obvious one of wanting to know what is happening, when it's happening in terms of infections, and in most instances, just clinical cases. So the first activity is to monitor disease activity at the local, state, and national levels, and the timeliness of that obviously is critical. Conduct disease control interventions. Only through knowing what's happening in our communities can we target the issues. For example, in our state today, a major challenge for us has been outbreaks associated with bars and restaurants. Only through disease surveillance we're able to really understand that. And then to define the epidemiology and burden of COVID-19, something that remains a challenge given the large number of asymptomatic individuals that are part of this pandemic. Also, in terms of enhanced surveillance during pandemic response, how do you monitor and predict the impact on the healthcare system? A mark that is frequently being used in terms of trying to understand when certain restrictive actions may need to be used in order to be certain that the healthcare system is not overrun with patients. Monitor changes in antibody prevalence over time. How do we know what's really happening with the outbreak? Inform modeling activities where those are used and appropriate, and to monitor viral changes over time by understanding what is actually happening with the virus itself. Next slide. In terms of pressing issues today for COVID-19 surveillance, one is the limited COVID-19 testing, especially early on. We are well aware of the challenges that we had flying blind in the earliest days of the pandemic here in this country. We also have had continued challenges. I wrote an op-ed piece in the New York Times back in April about what would be likely the scenario unfolding through the summer months of inadequate testing, particularly when we saw the increased number of cases that came to fruition. One of the things we need to be doing right now in terms of surveillance is anticipating this very testing issue, and you'll hear more about that from Marty Burke in a moment. Clearly, mildly symptomatic and asymptomatic exposed people, what to do with them, the issues of what has been called quarantine relative to what they should do and shouldn't do in terms of transmitting in our communities. We have problems with inconsistent data collection and reporting. A great deal of that often has to do with systems that have been overwhelmed by the sheer number of cases. When we say an area is a house on fire, that is often a true situation in terms of trying to do surveillance. A very non-specific case definition, other than testing itself, we still don't have a clinical case definition that we're able to use in the absence of testing. The issue of clustering of cases detected in outbreaks. How do we handle that from the standpoint of actually determining that to be the case when we may have individuals who will not participate in contact tracing or follow-up, and how we understand the extent of those clusters occurring. Difficulty in assessing exposures. Many people will report little to no information about where they think they might have picked this up or what their activities were 1 to 2 weeks before. The lack of timeliness and regularity of reporting has surely been an issue that's been in the media, where we see states sometimes reporting cases literally weeks later because of a backup in the reporting system, including testing reports being sent to state and local health departments. And then just a lack of an integrated reporting infrastructure. We often find ourselves in local areas still using fax machines. We find ourselves on a national level not yet having the kind of infrastructure we need for rapid and comprehensive reporting that also does validation checks to make sure that the data, in fact, are as they are supposed to be. Next slide, please. We've realized what the cost can be of not having adequate surveillance, in this case, testing being a key piece. This is an article that was just published this past week on our CIDRAP news site, but it details a study that was reported by the University of Washington and what happened in the early days of the virus transmission in the United States, and the fact that we were flying blind led us to conclusions that were in fact not correct, also did not allow us to fully understand the breadth and depth of what was happening. Surveillance is absolutely critical. It is the intelligence that public health must have. Next slide. In terms of the issue also of incomplete data, we continue to see challenges with certain categories of data. One is the incomplete racial data on COVID-19 cases. Again, another current recent article where it looks at the issue of the level of racial data collection, finding that in some areas, large segments, more than half of all the reports lack such data. This has been a very important issue as it relates to the fact that we do see such disparity in the impact of COVID-19 by race and ethnicity, and so that this is a critical function that surveillance must be able to collect and provide in a timely way. Next slide. One of the other areas I just want to comment on, while Marty's going to talk about testing, and I don't want to, there's another document that we've produced on what we call smart testing. And I only want to talk about it not from the testing perspective as such, but what the results tell us. In this document, another one of the COVID-19 CIDRAP viewpoints, we define smart testing as having the right infrastructure for testing, the right population. That's what I really wanted to hit on. Who should we be testing, when and where? We have to understand for surveillance purposes, there will be differences in whether it's the clinical case that we absolutely need and want tested today, whether it's contacts, or whether it's samples in the community to try to understand more fully the epidemiology of the disease. So how we pick the populations for testing becomes very, very important. That then gets us down past the right test, which depending on what our purposes are for surveillance, such as the use of serology, antibody serology, something that has only very limited use from a clinical perspective, has tremendous use from a surveillance perspective in terms of monitoring the ongoing level of infection in a community. Even with challenges around the false positive rate of antibody testing today, we can determine with serial sampling, meaning time A, time B, and time C, we can basically find that the error in terms of false positive is in a sense baked into each one of those. So if a sample at time A is 8%, at time B it's 10%, and at time C it's 15%, that gives us a relative perspective of the changing incidence and prevalence of the infection. And then of course we want to use this to take the right action. And this is where we want to enhance more surveillance of the ability to detect more cases quickly to also attempt to limit transmission. Next slide, please. So what are the challenges to COVID-19 surveillance? One is just adequate resources to test the population. Since this is still such a highly dependent part of determining if someone has been infected on us to have testing, we clearly need that kind of access. And we're going to be hearing more about that, but this is critical. Willingness to test. I have real concerns about what we've seen over the course of the past several months in terms of going from not enough testing being available to now having more testing because people don't want to be tested. We've seen that with people, for example, who challenge the very validity of this pandemic. Many of them refusing, even with clinical symptoms, to get tested when they first become ill. We've seen that with certain events. The cyclists who went to Sturgis, South Dakota, we found that even when they came back and developed clinical symptoms, did not want to be tested. We're seeing that now in college campuses. We have some college campuses reporting over 50% of the students refuse to be tested and or refuse to give any names of contacts that then might be followed up on. And we're going to have to follow this carefully, because this not only is about trying to understand the relative tip of the iceberg, knowing that even with acute clinical cases and testing, we'll never, ever truly define what's under the water level with that iceberg, but the top of it has been a relative number we've been able to use. And so the challenge we have is, if people are not refusing to get tested today, even when mildly clinically ill, what does that mean? And then, of course, the use of technology. We need to see a major improvement in that fax machine-based surveillance. Oftentimes, we're kind of more or less trying to put things together with baling twine and barbed wire at state and local health department levels, and the connection with healthcare facilities also challenging. We've already heard about that in terms of data reported from hospitals, et cetera. If there's anything we need to take away from this pandemic review, is the fact that we need desperately to upgrade our technology. And then finally, trust in the public health system. We have had real challenges, as you know, over the course of the past months with the government agencies like CDC and FDA. There has been more than enough public discussion of challenges about the validity of the information coming from those areas that then often will translate into the public's trust of even state and local health departments. And the compliance with contact tracing, as I made a point earlier, is very challenging in many areas today, where we're seeing people who do not want to participate in any kind of follow-up with regard to surveillance because of their distrust of government and the public health system. A very, very major point. Next slide. So as we move forward, I think we're going to actually go from a problem of not enough to too much, if you can say that too much means it's not all being used. I think that we can see, as we're slowing down testing in this article in the Washington Post from May, but we're actually now seeing it happen again, where in fact we're seeing testing actually drop off in areas where at one point we had hoped that we would continue to see participants, particularly who are ill, come forward for testing. Next slide. One of the areas we also have to understand is our connection, not just between local health departments and state health departments as well, and to CDC, but how do we connect to the hospitalization surveillance network, the data there. We've already had challenges trying to connect with healthcare facilities and healthcare systems to obtain information in a timely way. And this too has to be seen as a priority. Trying to fix systems in the middle of a pandemic is not something we should be doing. And yet we have found ourselves doing that very thing because of the antiquated and incomplete systems we had before. Again, another lesson to be learned. Next slide. And let me just close off here in a set of recommendations that we came forward with regard to our COVID viewpoint. I might add that if you look at the document, you'll see that a number of the authors are former CDC employees, people who have spent a great deal of their life working on this very kind of issue. And hopefully that wisdom is reflected here. Number one, state-by-state assessment of COVID surveillance practices needs to be conducted to identify inconsistencies in timely case detection and reporting to determine the resource needs. Since the Council of State and Territorial Epidemiologists establishes and implements the use of national case definitions, it should conduct the review in collaboration with the CDC. So CST has to take a lead role here. Number two, information from this assessment can then be used to develop a national standardized approach to COVID-19 surveillance by the states. The approach needs to adapt to the changing epidemiology of the pandemic and as new data on the nature of the disease are published. Number three, automated electronic reporting should be incorporated into surveillance whenever possible. And the federal government needs to provide the additional resources needed to develop such systems. Number four, states should publish on their COVID-19 dashboards, standardized and detailed data for demographic subgroups defined by a combination of age, gender, race, ethnicity, and location. These should be publicly available if data privacy can be maintained for different periods so the temporal trends can be analyzed. Next slide. And finally, at number 5, a coordinated campaign at the federal, state, and territorial level with consistent guidance from the CDC regarding key messages is needed to inform and educate applicable facilities, commercial and clinical laboratories, healthcare providers, and facilities on what information is required and why it is important. Number 6, state and local health departments need to have the data systems, informatics expertise, and trained epidemiologists necessary to conduct effective COVID-19 surveillance. This includes upgrading data, surveillance infrastructure, and ensuring federal support to provide resources needed to accomplish the goal. Number 7, the CDC should implement the agency's surveillance program as quickly as possible. 8, the CDC should continue to promote consistency for COVID-19 surveillance across the country and to ensure that a cohesive national surveillance system emerges by the end of 2020. And finally, with the fall influenza season approaching, federal, state, and local, tribal, and territorial health officials need to begin now to determine strategies for coordinated surveillance for both COVID-19 and influenza. So with that, I will conclude and thank you very much again for having me, and I look forward to our discussion and further elaborating on these issues. Thank you.
Great, Mike, thank you so much. Very thoughtful as always. I want to just thank all of you who are sending in questions and remind you, if you've joined us later, that you can submit your questions to apha@apha.org, and we'll have an opportunity to get into them during the Q&A session that'll follow our next 2 presentations. Now we're going to turn to Dr. Burke. Dr. Marty Burke is going to tell us about his experiences around testing at the University of Illinois and help us understand what that looks like for nationwide testing as well. Marty, over to you.
Thanks so much, Dr. DeSalvo. I really appreciate the opportunity and really excited to have the chance to share with you our story from the University of Illinois. If we could go to the next slide, please. So back in April, our administration reached out and asked me to stand up and strategically deploy a scalable testing program as part of our university's effort to open and stay open as safely as possible this fall. So the first thing we realized is that this was all about safety. So we dubbed this program SHIELD to emphasize that emphasis on safety to empower our community to engage in our critical mission of teaching our students, performing research, and engaging with our community partners. The next thing we realized is that testing was going to be really important, but testing is not a silver bullet. When we really tried to run through kind of thinking about what it was going to take to pull this off, we realized it's going to have to be done in concert with really smart decisions about who to test, when to test, how often to repeat it, as well as how to communicate those results in a way that was maximally actionable and highly impactful for mitigating disease spread. So we called this our Target, Test, and Tell program, meant to represent kind of a comprehensive nature to it, in concert with other mitigation strategies that we also knew were going to be important. The last thing, a key message I want to make sure to send is that we recognized very early that the protocols and tests and strategies that were available were probably not going to be sufficient. So there's just been a tremendous amount of innovation amongst the team. At Illinois, we love to innovate, and this has been a big part of the story thus far, and I'm excited to have the chance to share it. If you go to the next slide. So as mentioned, we really thought of this as kind of a 3-part comprehensive program. So we like to think of this not as a testing program, but a program that involves important tests. So target side is meant to be our kind of epidemiological and data modeling, in which from kind of a de novo perspective, we've tried to anticipate who needs to be tested and how often in order to give ourselves the maximum chance of mitigating spread. I'll highlight just a few of those kind of key aspects in a moment. The second piece is our test, and as I'll describe in a little bit more detail, we realized early on that the nasal swab was not going to be sufficient, and so we're going to have to find a way to make a test that's much more kind of cost-effective, much more scalable, and much more easier to perform on a regular basis. And so I'll tell you the story of how we developed a new saliva-based test that goes directly from saliva to PCR and has key features that make it very fast and very scalable. The last piece on the tell side is we realized in order for this to be effective, the information that we generate during the test has to be rapidly communicated to individuals in a way that allows them to make smart choices to stop them from spreading it to others. And so we've done this via a very strong partnership with our local Champaign-Urbana Public Health District and manual contact tracing. We've also created a new app called Safer in Illinois, which allows the results to be directly communicated to the user's phone in a fully HIPAA compliant and privacy first manner. We also have directly now engaged in direct contact with individuals within our own community through a new component that we added on when we realized this part could be improved. And I'll describe that in detail as well. Last piece I'll emphasize is we've been constantly updating and adapting and optimizing the protocol as we go. And so I think that flexibility and adaptability has been a key overall component. Okay, next slide. So very briefly on the target side, we have an outstanding team of data scientists and mathematicians and epidemiologists who helped us try to scope out what this would look like if we did nothing, and then what types of mitigation bundles would give us the best chance of success. So in summary, if we did nothing, the modeling predicted out of our entire community, pretty much everybody would get infected with COVID-19, and it would happen quite quickly. We're actually about 30 to 50,000 people on our campus. So this is actually, I think, a pretty good cross-section of a large community population. And unfortunately, this looks like this would be normal in most of those situations if we did nothing. In contrast, the modeling told us that if we were able to test everybody, so all 50,000 people, twice per week, as well as high levels of compliance with masks, social distancing, for example, classes greater than 50 online, as well as manual contact tracing, that if we put these things together, we would have a very high chance of being successful, leading to a nicely controlled number of total infections. They would be manageable by our public health. We would not overrun our hospitals, and that there would be a bump when our students first came back that we would expect, 35,000 undergraduates coming from all over the country and the world. We would get several hundred new cases brought into our community, but that would quickly be crushed by fast, frequent testing. We'd reach a nice, low, steady state and be able to stay open safely for the semester. Our community could thrive, our businesses could stay open. It was a very optimistic prediction. I'm very excited to tell you, as I'll show you at the end, that largely this has come true. We did end up with a challenge in which some of our students made bad choices about their socialization behavior, which caused an extra bump that we did not expect. I'll tell you all the details of that. But even with that challenge, the fast, frequent testing combined with the other mitigation measures, we've actually now managed to get those numbers way back down to where we started. And we feel very hopeful now that this is going to be an example of how a community can stay open safely. Next slide. I just want to also emphasize a point that the testing, again, is not a silver bullet. It has to be done in combination with other mitigation measures. And our modeling actually shows this. So if you just do the testing alone, you get a nice reduction in predicted cases. But if you add masks, social distancing, and contact tracing, you get a very dramatic and, in fact, synergistic effect of these combinations. So it really has to be a holistic approach with lots of community engagement in order to make this process successful. Next slide. So when we thought about how to achieve twice per week testing of 50,000 people, the first thing that became clear was the nasal swab was not going to work, as I mentioned. And we started to look for alternatives. So we became very excited about saliva as an alternative, and there were good logistical and scientific reasons for doing this. From the logistical side, people don't like the nasal swab. It's uncomfortable, and it's difficult to imagine people being willing to repeat that twice a week for an entire semester. In contrast, the saliva sample, you can imagine, actually is very easy to collect. It's something that's non-invasive, and you can imagine a system where this becomes just a regular routine as part of your day. It avoids the swab. It also avoids a lot of supply chain bottlenecks, as I'll emphasize in a moment. You don't need, or you need less, of healthcare workers to be involved. It's much easier on the patient. And there were some really nice reports that had come out showing that it was compatible with fast, frequent testing in theory. And if you could do this, even if the test had less sensitivity, if you were testing fast and frequently, it actually could be very effective in terms of mitigating spread. Now, on the scientific side, there were some also really promising reasons to think about saliva. The first, and we think really important, is that saliva is how we spread COVID-19. It's through our droplets and the aerosols that our saliva create. And so we're, in a sense, directly and, in fact, quantitatively assaying the amount of viral load in the saliva. So as a way to understand infectiousness, it actually becomes a much better medium to look at. There was also a very encouraging report out of a group at Yale back in April, which really further encouraged our looking at saliva. And that was, they showed you could detect SARS-CoV-2 even more sensitively in saliva than the nasopharyngeal swab. And this has actually been consistent with our experience as well. So next slide. So in thinking about, again, the standard method at the time when we were starting this, it was the nasopharyngeal swab-based approach. Not only is it uncomfortable, but the swab itself is an important supply chain bottleneck. And then you have these same challenges all along this four-step process. So then it goes into a viral transport medium, which is also a supply chain bottleneck, and it causes another delay. RNA purification, which requires a special kit and usually another machine. And then finally, the RT-PCR reaction, which is where you get the information about the viral load. If you click, there had been a report that had come out showing saliva could work, but this original version actually involved a very expensive specialized collection device. It still involved the RNA purification, and overall actually ended up being a very expensive and not a more efficient way to do it. So if you click again, my colleague Paul Hergenrother in the Department of Chemistry had a really, I think, brilliant idea to go directly from saliva to PCR, cut out all the supply chain bottlenecks, dramatically streamline the process and make it much cheaper. And this is ultimately the result I'm excited to tell you about we were able to discover. Next slide. So the process actually turns out to be remarkably simple. The team discovered that if you simply heat saliva at 95 degrees for 30 minutes, you inactivate the virus, which is critical and allows you to process it in a much safer way on scale in a large testing lab. But also we think it breaks the virus open and thereby exposes the RNA and allows it, upon transfer to a buffer, to be directly applied to a PCR reaction. So you take a 20-cent tube, dribble into the tube, heat it, and run the PCR. It really is that simple, and this actually had a dramatic impact on the scalability. And as you can see, our level of detection, in fact, rivals and is more sensitive than most nasopharyngeal swabs. In fact, we've now shown it's even more sensitive than other saliva-based tests. Next slide. We also had to form a lab to do this. So it's actually a really cool part of the story. Our veterinary diagnostic lab is fantastic on the University of Illinois. You may have heard back in February, there was a tiger at the Bronx Zoo that had been diagnosed with COVID. That was actually done at Illinois by Lei Wang, who's an animal coronavirus specialist. And here's my colleagues, Paul Hergenrother and Tim Fan. We all teamed up to transform our veterinary diagnostic lab into a human COVID-19 testing facility, bought a bunch of PCR machines and robots. We were able to actually reach capacity up to 20,000 tests per day in our veterinary diagnostic lab. Next slide. Just a bit of the logistics that allowed us to achieve that. So we were able to pop up about 20 different tents all over campus. Each tent has 2 lines, so students or faculty and staff can simply walk through. You swipe your iCard, it generates an order, it goes on your tube with an RF code. You submit your saliva sample and you put it into a rack. And then we've got golf carts running those racks down to the veterinary lab on the hour. And this allows the whole process to be very efficient and easily collect up to 20,000 samples per day. And since July, we've now run more than 300,000 tests on our campus. A really key point is that the results come back within hours rather than days. And when we look at the effectiveness of mitigation of the disease spread, the time window between when you start to collect the sample and when you finally get someone safely isolated, that time window is the absolute critical factor in terms of efficacy. And so a fast test was a really key part of the story. Next slide. The other piece, as I mentioned, is how to communicate those results and achieve very effective isolation and quarantine. So we've been working very hard on this, and we think we've learned a lot along the way. One of the key things we did is we created an app that actually allows the results of the test directly to the user's phone in a HIPAA compliant and privacy first manner. This allows the rapid communication in a way that young people are used to dealing with. And it also has a really nice feature in which there's an opt-in exposure notification that's proximity based as opposed to GPS. So people feel very comfortable using this. It's actually a very private and secure way to understand if you've been exposed. And we've actually had a lot of uptake. People actually are using this app, and we think it's making a big difference. If you flip the next slide, the other key piece of the app is that there's a cover page that if you are up to date on your testing and you are not positive, you actually get a check mark on the cover page, and you need to show that to get into any building on campus. So coupling your compliance with the testing program with activities that you want to do has been a very powerful mechanism to actually get people to participate in a way that I think has made a big difference. If you're not up to date, or if you've tested positive, you get an X mark, and this means you actually have to get that rectified before you're able to gain access back into any building. The other really interesting thing that's happened is our community has now started using this. So to get into bars and restaurants around campus, you have to show your app, and that's a way to ensure safe engagement in those community activities and our businesses, and it's actually turned out to be a really good boost for the economy and the community as well. Next slide. Okay, so the most important slide that I'm really excited to share with you, these are our latest results that have been updated as of even up to yesterday. So as I've told you, we've performed now more than 300,000 tests. The upper right-hand corner is our 7-day rolling case positivity rate. So I'm very happy to tell you that right now we're at 0.44% for our positivity rate. The plots below, the orange line is our case positivity rate per day. And I'll talk about in just a moment some of the trends that we've been able to observe. The blue bars are our new cases per day, and the green bars on the bottom are the number of tests that we perform per day. So a couple of things to highlight. The y-axis on the bottom plot, that is up to 20,000 tests per day. So you can see this has been a massive testing operation throughout. Moving to the top plot, you can see during the month of July and early August, we ran kind of a pilot. This was with our faculty, staff, and students who were still around campus. And you can see we got some really encouraging hints that this could work. We were up around 1.5% in the mid-July, and then we watched this drop below 0.2%. And we almost eradicated COVID-19 from our faculty, staff, and students. Then we brought our undergraduates back, and we knew from our modeling that there was going to be a bump. Okay, we expected there would be a rise, and in fact, consistent with our modeling, we saw several hundred cases come in. That was during that first, let's say the third week in August. And then our modeling predicted we would drive this right back down. Now, we had been very kind of cognizant of the fact these are young people and they're probably not going to be perfectly compliant. We had modeled in that thousands of students would probably go to parties 3 times a week. They wouldn't wear masks. And yet the modeling still predicted we would crush the pandemic once they came in. What we didn't model for, and if you could give me one click, that unfortunately students made some really bad choices that we didn't expect. Specifically, students who were known to be positive, having confirmed that by our test, chose still to go to parties or host parties. And this caused some events that really led the numbers to spike. And so you can see there, we actually almost reached 3% positivity rate. And we were able to directly connect this to those activities because we saw exactly where these spikes happened, and they had correlated exactly with where we got reports of these parties. Now, 2 things I really want to emphasize. Because we were testing everybody twice a week, we saw this immediately. So the fast, frequent testing gave us a very early warning signal that something was wrong. And that allowed us to very quickly make pivots and make changes and adjust so that we could address it. So if you click one more time, we made 3 key changes very quickly that I think ultimately had a really strong impact in the positive direction. The first is we looked at all of our data and realized greater than 95% of all of our cases were with our undergraduates. So this allowed us to put a specific essential activities only order in for just the undergraduates. Now, we're very proud. We never closed down classes. We never stopped research. We allowed the undergrads to continue to go to work, but we forced them to not engage in any types of parties or any other socialization in large groups, which had a big impact on mitigating spread in that group. We also changed our testing strategy. Instead of continuing to test everybody for twice a week and fishing in the whole ocean, we said all the fish are in this little pond, let's go fish in that pond more often. So we tested some of the undergrads now 3 times a week, particularly in cases where they had high incidence in their houses. We had everybody else in undergrads twice a week, and then everybody else just once a week. And so that allowed us to increase the turnaround time of our testing, which also had a good positive impact. The last thing is we realized we could get much better at helping people isolate safely quickly. We were working with Champaign-Urbana Public Health District. They were doing their very best, but it took sometimes up to a day to actually get that information and get people isolated. So we're missing out on this very large window of time. So we launched our own internal team. We called it Shield Team 30. The goal is within 30 minutes, we ourselves contact the students and help them get safely isolated. And I'm happy to tell you this worked really well. Usually within a few minutes, this team has contacted folks and gotten them isolated, and we think that's really made a big difference. All of this together, you can see the result. We watched those numbers drop right back down, and we think this is the really exciting example of how fast, frequent testing combined with other mitigation strategies, it can work. And it can, in this case, show that a university community can stay open. 2 other things to highlight. We worked very closely with Champaign-Urbana Public Health to look at this. We saw no crossover into our community, and we saw no crossover into our faculty and staff. So because we acted quickly and went on offense instead of playing defense with our testing, we were able to stop the spread into other groups. No one ended up in the hospital, and we've had no serious illnesses. Next slide. So just to summarize, we think we've learned that fast, frequent testing can help mitigate the spread of COVID-19, specifically in our case in a large university community, but we think the lessons we've learned can be broadly applicable to many others. To highlight, testing is not a silver bullet. It has to be integrated into a holistic approach that includes the epidemiological modeling, contact tracing, masks, social distancing, and really importantly, community engagement. We have to be all in this together. The iCovid test that we developed, it's a direct saliva to PCR, enables fast, frequent testing on scale, and that heating step as the first step allows it to be run safely on large scale and protect the workers. Prioritization of testing can really help maximize the impact, and in mechanisms to help people that test positive get safely isolated very quickly, and then supporting them and in fact enforcing that isolation and quarantine are really important. Okay, I'll stop there. Of course, I'll be happy to answer questions. Thanks so much again for the chance to tell our story.
Great. Dr. Burke, thank you so much for that inspiring story about leaning in and scaling at the university, and appreciate those insights. And our last speaker is Dr. LaQuandra Nesbitt, who is going to talk with us about this additional tool in the public health toolbox of contact investigations. Dr. Nesbitt, I'll turn it over to you.
Thank you so much, Karen, and thanks so much to APHA and the Academy for inviting me here to talk a little bit this evening about the role of contact tracing and to share what we've been doing in the District of Columbia and our lessons learned about some best practices, but also some things that we know that we've learned that could be done better in our jurisdiction, and some things our colleagues in governmental public health and communities that are doing this on behalf of governmental public health can do better. Next slide, just to kind of level set, there's been lots of talk about contact tracing since the COVID-19 pandemic has begun, but contact tracing or disease investigation is a core function of public health, and we do it routinely to be able to respond to tuberculosis cases and other infectious diseases. And as you've also noticed on this slide, there's a huge connection between the surveillance work that was covered earlier by Dr. Osterholm, and Dr. Burke just talked a lot about the role of testing and how critical both of those functions are to being able to respond to this pandemic. And so we're going to spend a little bit more time talking about the process of disease investigation and contact tracing and how that can play a tremendous role. Again, they've given some insight into how important it is, and all three of these things are so intimately linked, which is why we've been spending time talking about it. What we've done in the District of Columbia, and some communities have done things differently, is we have kept the role of disease investigation and contact tracing linked in our agency. And so when we have a case that's identified, our case interviewer does the full gamut of work, from being able to assess the individual in terms of their clinical history, whether or not they've had any signs or symptoms, being able to explain to them what they need to do in terms of isolation, and also getting information about their contacts. They also contact the contact and provide them information about what they need to do in terms of quarantining, and advising them of what they should be looking for in terms of symptoms, and advising them of the need to be tested and what our recommendations are for testing in our jurisdiction. There's an assessment of any social support that may need to happen in terms of being able to isolate and quarantine successfully. So all of that is done in a comprehensive approach. Some jurisdictions have separated the disease investigation and contact tracing functions and have had myriad success, or different types of levels of success, because of the bifurcation of those responsibilities. And that may be something that we'll learn more lessons from in terms of the level of success that you have when you keep those functions combined versus when those functions are separated. The other thing that I want to make sure I highlight early on is that there in public health, when we're responding to a pandemic, there are periods of time where the number of cases, we call it the acceleration phase, increases so substantially that the ability to responsibly conduct contact tracing for every positive case is markedly compromised, versus when you may be in a deceleration phase, or you have fewer cases, and we may quantify this as cases per 100,000. So you may have to either suspend contact tracing or prioritize the types of types of cases that you're going to conduct a contact tracing for, and they may be for populations who are the most at risk. This can be determined by setting, or if particular communities in your jurisdiction are experiencing a disproportionate burden of disease. Next slide. So what I'll talk about here are some things that we've recognized can assist us. So I recognize it again, I mentioned testing is a key part of our strategy, how quickly we isolate and quarantine individuals after they have been tested or identified as a contact through the tracing process, are what we recognize to be the core measures to stop the spread. But if you advance for me, we'll also be able to talk about what we've recognized as to be the enablers of these other things, the testing, the tracing, isolation, and quarantine, that have made our efforts be more successful. And I want to talk a little bit more about all of those things, the testing, tracing, isolation, and quarantine, but more importantly, what we've had to do in terms of building public trust, how we use technology as an enabler, and how policies help to enable our work, but also how sometimes we have to be flexible, especially in the area of policy, to make our efforts more successful. On the next slide, I'll talk about testing. We started very early on with the approach that many jurisdictions did in trying to ramp up the availability of testing in our jurisdiction. I won't go into the details in terms of talking about types of tests, but we focused on putting mass testing initially in our jurisdiction in the communities where we knew healthcare access was most likely to be the most limited, and where we would see our surveillance data was telling us that we were going to be experiencing the most disparities in COVID outcomes. So that's where we focused initially. Then we began to expand our testing. You'll see these little fire engine graphics, because we started to use something that's spread equitably throughout in most jurisdictions, and that's access to firehouses or fire stations. And we put more resources for testing in our local firehouses. It's a place that people trust, and it kind of links to that public trust domain. And if you advance one more for me, this helped us, along with expanding and getting our providers to do more testing after we addressed issues of concern for keeping their workers safe, healthcare workers safe in the ambulatory environment, being able to better segment healthy patients who were coming in for preventive health services, for patients who had COVID symptoms, helped us to rapidly increase the number of tests per million that we are doing in our community, up to goals that we had set for ourselves. On the next slide, I won't spend a lot of time on all of the different things that are set here as our broad goals that we have for our agency, and some more specific goals that we have for the contact trace force. As I mentioned before, disease investigation is a core function of public health. And Dr. DeSalvo shared the 10 essential services for public health at the beginning of our session this evening. But I would be remiss if I didn't highlight that at the beginning of our response, or prior to COVID-19, we were an agency that had about 26 FTEs who were dedicated to sort of the disease investigation, epidemiology work within our agency, where contact tracing was part of their function. And now we're at a workforce that has over 560 FTEs if we're counting in our reserve corps that scales up to this work. And that's been expanded through a combination of new hires, staff that's been detailed from other functions across the district government to be able to respond to this work. And they work at various levels. This includes those who are doing the direct work of the interviews, as well as the investigators and the supervisors. So really a huge expansion to be able to respond to the demand of this work based on the amount of cases that a jurisdiction our size is experiencing. On the next slide, I want to make sure that we highlight here what it really looks like if you're doing case investigation and contact tracing in combination. And this will be a great transition into the importance of having these enablers. When you think about having hundreds of people doing this work, and also making sure that we take note that we're trying to social distance in our operations as well. And so much of this work is done remotely. And you want to have fidelity to the process, because the data that you collect in your contact tracing is a part of your surveillance data. This helps you to manage your pandemic in your jurisdiction. The testing data is surveillance data, but contact tracing information gives you insight into the pandemic, the qualitative and quantitative aspects of the pandemic in your community. And so if you could imagine that having people do this work in a pencil and paper type of work would make it very difficult to do analysis of what the pandemic looks like, or how to manage logs of information of contacts and then communicate with those contacts. And so technology has been a tremendous enabler of this work, and helping us be able to call interviewers, call and conduct interviews with positive cases, maintain logs of close contacts, and be able to understand to what extent close contacts become positive cases, and what the relationship is between cases and contacts, as well as locations throughout the city and in our neighboring jurisdictions, which becomes extremely important when you have bi-state and tri-state relationships. On the next slide, I just want to be able to highlight, again, sort of getting into these key successes and the enablers that we have, and being able to leverage technology. Again, there's a number of entities that are out there that are supporting this work. We went with one particular technology partnership with Accenture. And this is where flexibility becomes extremely important. As our response has matured, we have needed to have the ability to make updates to our system. So recognizing that we engaged a workforce, some people were much better at with experience in terms of having done disease investigation before. Because of some of our recruitment efforts, we were very flexible in terms of just naming a type of skill set. Customer service was very important to was very important to us. And we recognized the need to build in different hard fields into our system. We wanted to be able to limit the amount of manual data extraction that our team was doing. And so we do updates to our customer relations management solution every 2 weeks to improve how that tool works for us. We've also recently signed on with the Google-Apple partnership for exposure notification to make that tool available for us. Adding on to supplement some of the things, and I'll talk about that for challenges, where we don't have as much information for contacts as we can, but this can help augment how people are notified if they've had an exposure, enhancing the work that we are doing with our contact trace force. And the last thing that I'll mention here is that contacting people is a cold call. And so you have to make sure that the number that is showing up when you're making those contacts, whether it's the SMS message or a phone call, shows up on caller IDs. And that doesn't happen all the time in the age of cell phones. And so we worked really hard to have our DC COVID-19 team show up on the caller ID for mobile technology. Building trust on the next slide was also extremely important for us. So we hire from community. Almost 100% of all of our contact trace force employees are the residents in the District of Columbia. We've worked to have credible messengers. So we have partnerships with our faith-based institutions, community leaders, as well as our local health and social service providers. We issued a number of grants to healthcare organizations as well as social service organizations. And many of those organizations, either as a requirement of their grant or independently, have taken training modules on contact tracing so that they would be familiar enough with the process to be able to explain it to individuals who either test positive or are contacts. And that helps them to be primed for the process with the government, helps them to understand what we will ask, helps to build trust around the process, helps them to understand that we're not going to ask information or pass information on to law enforcement or anything that will compromise their ability to be safe or feel safe in our community. On the next slide, we recognize that a lot of the key to success is being able to have individuals isolate and quarantine successfully. We found, and that's a picture of what some of our housing looks like in the District of Columbia. And we found that some of the other neighborhoods that we were having high rates of infection in were very densely populated. These are just traditional row homes in the district, but some of our other areas were apartment buildings where the number of individuals per household was much higher than the citywide average. And despite us having isolation and quarantine housing available in hotels, people weren't taking advantage of it. And this was information we were gleaning from our surveillance data. So we decided that we needed to go to another tried and true public health approach that we've used in our maternal and infant health programs, in some of our TB initiatives, as well as some of our other chronic disease management programs, and launch a home visit pilot to see if we could decrease the loss of follow-up and increase the number of individuals who completed interviews and provided contact information, close contact information, who were COVID positive. On the next slide, we have, it's just showing the eligibility criteria for that initiative, where we focused on those who had missing or incorrect phone numbers. Surprisingly, in the district, that percentage is very low. That's around 3%. For individuals who we had reached by phone, but for some reason we didn't finish the interview or weren't able to do our public health monitoring, or these were individuals who, when their case was reported to us by their healthcare provider or through a community-based organization, identified them as having complex needs that may make it difficult for them to isolate or quarantine. On the next slide, I'll just share with you some of the preliminary findings that we've had. Prior to the visit attempt, the outcome, we couldn't reach. This is very interesting, about 60% of individuals, which is very concerning when these should be individuals who are quarantining or isolating. Even more interesting is that 13% of individuals for who we had a successful attempt at reaching them, someone in the home reported to us that they were not there, and that perhaps they were at work at the time, and these are individuals who have tested COVID positive. And then lastly, for those who we were able to reach successfully, we were able to complete about 40% of the interviews, and 60% of them are still incomplete. And the average time to completion for an interview when they were successful was about 1 to 2 days. So these are some of the things that are still very concerning about, as Dr. Burke mentioned, the ability to have community really engage with the contact tracing process and some of the other community mitigation factors that we know could be very successful. This is not something unique to the District of Columbia. When we talk to our peers in other cities who have launched home visit pilots, they have seen similar results. This is something that we're going to be focusing our efforts to try to address earnestly. So just in closing, I do just really want to highlight that we have found some things that work, that are successful. If you have the core components of a program, if you're leveraging technology, if you are adequately staffed, you really can have a successful contact tracing program. But we really have to address the challenges of having adequate community engagement in order for contact tracing to be successful in any jurisdiction. I look forward to an engaging Q&A discussion. Thank you.
Well, that's fantastic. Thank you, Dr. Nesbitt. And I know you and your team have been going full out for months. So thank you for making time for these learnings today. If we could move to the next slide. We're going to move into our Q&A session. We've had quite a lot of questions come in to apha@apha.org in case you still have any you want to send in. But I may just go ahead and move straight into some of those because they are aligned with some of the things that I would like to hear more about from these panelists. So thank you guys for bringing forward some questions. I'm going to start by directing a question maybe to one of you guys, but some of these seem very appropriate to have multiple responses. So please feel free to chime in and share your perspectives, even if I don't ask you to lead off in the question. I want to start off with a tough question for Dr. Osterholm, excuse me. Mike, I think this is less about you, but just more about the state of our surveillance system in the US. The question is, why were we caught so flat-footed when CDC reports were sent out January 8th that a new pneumonia was detected in the Wuhan province?
Well, I think part of the challenge was, in fact, that we really did lack, I think, creative imagination to expect that this could be a pandemic. You know, this is not a partisan issue. This is not a issue that I think divided public health versus others. You know, I put out a statement on January 20th saying that this was going to be a global pandemic. We needed to prepare and get ready. It still was another 7 weeks before the WHO declared a pandemic. During that time, I received a fair amount of comments from people across the spectrum, including public health, that basically were critical for us putting statements out like that, saying that this, in fact, we were scaring people needlessly. A major medical journal published a cartoon in its journal actually comparing flu with, at that time, the status of COVID, suggesting that we were really blowing the COVID issue up far beyond what was its appropriate level, and that influenza would still kill many more people. And so I don't think any of this was, you know, in any way other than just people couldn't perceive what was about to come. Mm-hmm. We had planned for influenza pandemics. And so since this was an influenza, and since we'd had SARS and MERS and had been able to control it as a coronavirus, people just assumed that was going to be the case. We took a lot of heat from a number of people for what they thought was an overhyping of the 2009 H1N1 pandemic, which ironically, if you actually look at years of potential life lost, exceeded that of 1966 or and 1967 and 1957. If you look at the issue of the Ebola situation, where one estimate from the CDC as a model, even though I grant you it was the upper range, said up to 1 million cases would occur, people were really afraid to, oh my God, here we go again. We're going to scare people and it's not going to be for real. And so I think that that was a reason why there was a reluctance by a lot of public health officials, as well as across the political spectrum, to realize and acknowledge that this was coming and that we were really ill prepared for it.
Yeah, thank you. That you know, a related question that we got was about sources of data, and we have a couple in this vein. And one of the things certainly that always frustrated me as a local public health leader was how stale the data was that I typically got. In some cases, especially for chronic disease surveillance, could be a couple of years old by the time it was packaged and presented to us to respond to or take action on. I wonder if, LaQuandra, you have any thoughts about the state of data insights or signals that you get as a local health officer on a daily basis, and what's missing, or how you think that could be improved, not only today, but certainly going forward into the future. And anybody else chime in if you have some thoughts about that too.
Sure. You know, as I mentioned before, the pandemic response continues to mature. And we've had a lot of discussion about surveillance and how surveillance is going to change over time with the response to the pandemic. And when we look at how we do surveillance for influenza, we don't monitor every single case of influenza that happens in the country. What we have is we have certain sites in our community that report on the influenza cases that they're seeing, the number of tests that they're doing, and that's how we monitor trends in influenza in our community. We consider them to be sentinel sites that are reporting. So it'll be a set number of hospitals, a set number of urgent care sites, a certain number of primary care provider sites. And as the flu season matures, we see changes and we compare it to what happened the year before. And we look at the types of influenza that are circulating in our community. Is it A, is it B, et cetera. What we have gotten into with COVID and with SARS-CoV-2 is tracking and documenting every single case. Initially looking at it with a real-time PCR test. Now we have more of these antigen point of care tests that are out that are going into doctors' offices, and the antigen tests are more along the veins of the rapid flu test. And it's going to be interesting to see how we capture data. We continue to capture data on every single test, on every single case. And Dr. Osterholm mentioned this, you know, what's the level of data quality? Are we getting every single test? We don't have a uniform clinical definition that we're using, and every state isn't reporting presumptive positives using a clinical definition. So I don't know that we have, when we talk about how accurate the data is, are we, by the beginning of the year, going to be doing surveillance for SARS-CoV-2 in the same way that we do surveillance for influenza? And I don't think the country is really prepared for that type of shift. Right. In terms of how the district is doing, we've got really great inputs. All of our laboratories are reporting electronically, so we aren't in the fax land, which has been remarkable for us. And it helps us do our job very well and do it very timely. But many of my neighbors who have people who come and work in my city don't have all of their data coming in electronically. So there's not a lot of equity in terms of access to data, which means there isn't a lot of equity in terms of the rapidity of the response.
Yeah, you know, I'm sorry, go ahead.
I was going to say, if I could just add one context to that too. I think that was very, very helpful and thoughtful. But I think we also need to understand there's a big distinction difference, yet a real complementary role for both surveillance and intelligence. And they play off of each other. For example, I mean, I'll just say, I'm not using intelligence from the quote unquote spy side, but, you know, we were able to glean substantial information from social media and actually with people on the ground. That's why we were able to say on January 20th that we believe that this situation was going to become a global pandemic. I've heard people argue about how much, you know, classified data were available or not. Well, you know, we did it on simple, just what's available. The same thing is true right now today. You know, we're doing intelligence constantly on how many college parties are occurring. Where are they occurring? How are the bars operating? Where are they at? I can go down a laundry list of different behaviors that really give us insight into where we might expect the next cases, where we should be looking more carefully to find cases with surveillance by using intelligence. And I think you have to link up intelligence and surveillance to have your best chance at, for a disease like this, where many will not be diagnosed with a specific test result. And that's really important.
Most definitely these novel signals that public health is getting better at using and that are all around us and are quite useful. You know, related to that, I think is the public health infrastructure, as Laquandra said, is there's some variability based upon capabilities, and we've all seen the pictures of fax machines. In some cases, though, the fax machines, for example, in Houston, were related to the fact that there were a lot of new laboratories doing testing that were not part of the data, the data use agreements that were already in place between public health and the health departments. And so it was people like you, Marty, standing up new laboratories who were gathering additional information and needing to feed that into the public health infrastructure. And so I think it's wonderful what you all are doing, but I wonder if you could give us a glimpse of how you all have partnered with public health so that the surveillance, essentially, data that you have can inform the work that they're doing at the local level.
Sure. So we went ahead and went through the process of getting a CLIA certification for our laboratory. And so as a CLIA certified lab, we are actually required to share all of our data with the Illinois Department of Public Health on a daily basis, which we do. But we also recognize the challenges of the current system is labs send to Illinois Department of Public Health, then the IDPH sends it to the local public health, and then the local public health starts the process of contacting folks. And we were worried about that time cost, you know, associated with that. So one of the things that we did early was we also formed a direct line of communication to our local public health. We have a fantastic public health team. We've had partnership with the university for now, you know, decades and decades through lots of different challenges. And we were able to leverage that relationship locally. And I think one of the things we've learned is that, yes, this is a national and an international problem, but hyper-local solution making can be very powerful. And so finding ways to empower communities, right? We all care about keeping each other healthy and getting our economies going, educating our kids, you know, getting things back on track. And I think the more that we can empower local solutions to some of these challenges is actually a really big plus. So that's why even with our local health provider, we weren't feeling like this isolation was fast enough. So as a university, we can actually, under FERPA regulation, actually have, faculty members and other people on staff directly contact our students and help them get isolated. And we got it down to within a few minutes of the positive test. So I think that was a really key pivot. Last thing I'll just say, I think surveillance testing, people think about testing as try to understand the problem. That's really important. What we, I think, have been able to do is also turn testing into go on offense and actually use it to help fix the problem. And I think that's really a challenge, but we've shown it can be happen. And we've also shown speed is the key. So I think that's also an important lesson.
Can I, before you go on mute, let me transition. We have a lot of questions on testing, and apologies to the audience. Some of them are pretty technical, so I'm going to try to stay a little bit more high level. But as always, there's a lot of interest in the area. And just as you are thinking about scaled population level testing that can have a rapid turnaround time, are you all looking at any additional technologies like testing wastewater, or this is one of the questions that came in about some of the even more advanced work or a next gen kind of work than what you guys are doing currently?
Yeah, so we looked a lot at wastewater as an option. I think to understand where you are is probably very helpful. Like you can probably get a lot of nice information from the wastewater. We couldn't convince ourselves that we would be able to complement what we were doing already. Since we were going to be testing everybody twice a week, that level of granularity and speed within hours, we didn't think the wastewater was actually going to help us. Again, that said, I think that we recognize it's not about just our tests, it's really about the program. And so learning how to take, whether it's wastewater or antigen tests or other types of testing, and try to turn it into go on offense and actually mitigate spread. There's lots of lessons learned from our experience and many others that we think can be leveraged to start doing this in many other situations. And in some cases, wastewater probably could be helpful.
Yeah, Mike, I've heard you give a really good synopsis of the utility of different types of testing, PCR testing or antigen testing or antibody testing, and we had a few questions in that category. So I wonder if Mike, if you could just share that synopsis of what's useful when and how the country should be thinking about applying these testing technologies. That was for you, Dr. Osterholm.
Yeah, first of all, this is obviously very complimentary to Marty, and so feel free to speak up. But first of all, in terms of diagnosing a clinically ill patient, really PCR still remains the gold standard. There will be, I think, challenges coming down the pike to understanding, based on cycle threshold and cycle time, what a positive really is in terms of infectiousness, and that already has been raised as an issue, and I think it's a legitimate one that needs to be looked at. But PCR is I think, the standard that we need to use. I have concerns about the lateral flow antigen tests that we're seeing out there. Having spent many years in the influenza area, I can tell you that many of these antigen tests, while they promote a sensitivity of 95 to 97%, in fact, they're much, much less sensitive. For example, the Binoc test that Abbott has out that they use for influenza, we routinely get 50 to 70% sensitivity, even though the package says it's in the 90s. The same thing happened, I think, with this most recent approval of the Binoc test for COVID-19. They got 34 or 35 samples right. That's the sum total data of positives that went in for approval. That would have been hard not to get those right like that, given what they could do. I would worry that the antigen test, which has been approved for clinical use, which should never be used for clinical use, should be used for screening. If in fact you're trying to look at experiences where you're at a place where you just want to test people who are well to see how to use that. The antibody test, as I've mentioned before, clearly we don't understand what that test really means. In low prevalent areas, even with some of the technology we still have yet today, half of all the positives will be false positives. Second of all is if you do have a positive, it's not clear necessarily if you have protection. Where I think the serology can be used and can be helpful is in the issue of, number one, identifying potential plasma donors who have recovered, who would want to participate in plasma donation. And the second area I think that we're seeing its use being helpful is actually among the long haulers, the people who early on were infected, did not have access to testing, did not have a positive at the time, but their ongoing chronic fatigue syndrome-like symptoms surely are a challenge. And we're finding that a number of these people are positive by serology, which helps the clinician realize this is a long hauler condition. So I think, again, just to summarize, PCR for diagnostic purposes, the lateral flows for the idea of screening, and antibody for surveillance. And I think that to me is the appropriate use for each of those.
All right, well, next time we have a webinar, we'll talk about CRISPR and other technologies that are on.
And there are others coming. There are many others coming. I think that's, I think you're going to see some graphene-based point of care. You're going to see a number of these are coming. But for what we have right now, that's the primary set.
It's an extraordinary time where science is being matched with traditional public health tools. Laquandra, I'm going to get you to start this next round. We have probably enough time for 2 more rounds of a couple more questions, but I want to start talking about something that weighs on a lot of us, which is the potential for there to be mismatch in capacity and in need. And we often talk about that as capacity and demand, though I think as you get into the local public health environment, sometimes you have a need for testing in a jail environment or some workplace environments or with certain populations that may not have all the resources that like University of Illinois would have. So I hope that all 3 of you will kind of weigh in on how the country should be thinking about our responsibilities about making sure that we're matching supply and demand in a way that is most equitable and ethical.
Sure, Karen. This is a wonderful question. We actually it was actually posed to us earlier today in a conversation with our legislators, because it's really, as you said, it's on a lot of people's mind. And when we talk a lot about the epi curves and what the epi curves look like, and we're always conditioning people to don't look at test positivity, or have people say, well, that city has tested all of its residents. And it's like, well, you have to look at it as it relates to the period of exposure and not, since the pandemic began. And I raised that to say, if we get into ourselves into a situation in this country where we have supply chain issues, we end up with long test turnaround times, we really have tried to get people to understand that we may have to prioritize testing as it relates to who's at the greatest risk for mortality and who's at the greatest risk for severe illness. And we've been able to explain it to people from the perspective of, in inpatient environments where there's a critical need to be able to think about it from the clinical management of the individual. Now that there are some potential therapeutic agents out there that could decrease mortality or at least decrease morbidity, you want to know what the individual has. And so making sure that those folks have access to tests and tests that can be turned around very quickly is always critically important. And the next line of thinking that I like for people to be able to have is we have to make sure where the risk of transmission is highest because people are in close proximity to each other can be addressed, and that our resources for testing are allocated to those environments. If we were in a situation where testing capacity was limited, and those congregate settings then have to be looked at from the perspective of, again, case fatality ratios. And we were making sure people could look at our data and say, well, there's a difference between the case fatality ratio in a long-term care facility and even in a correctional facility because of the underlying health conditions that those populations have. And then when we start talking about some of these surveillance programs where we really, and as Dr. Berg mentioned, we're testing 2 or 3 times a week on a college campus that has in-person instruction or has residential students, you can really begin to see how those resources should be allocated based on risk of exposure, risk of transmission, and begin to allocate resources differently. So again, as the pandemic matures and as we learn more, we can, if we had an issue again in this country where testing resources began to become limited, we have a lot more data about who's most at risk. And we would have to allocate resources based on that. I think we have to the last thing I'll say about this is that the non-pharmaceutical interventions would then have to come back into play if testing resources became limited. And we have to think about that augmenting the testing.
Thanks, Marty. I hope that you can weigh in because I'd like to hear how you all are thinking about it at the university.
Great. Yeah, so we are a land grant institution. Therefore, our charge is to serve the public good. And this is something we feel really passionate about. We feel like we've learned that we have a model that can be helpful. And we understand that it really has to be, again, testing is not a silver bullet. It's that we've learned that community engagement, the holistic approach, I think this is some of the most important things we've seen. So we've launched 2 different organizations, the goal of which is to help expand our capability to as many communities as possible. One of them is called Shield Illinois. We partnered with our governor and with our IDPH and with many partners across the state to get our testing out to the entire state. We're building 13 different labs in a population density map driven approach. We've built mobile labs. These are CLIA labs on a truck that can each do 10,000 tests per day. So we can go into communities that are particularly struggling, particularly those who are disproportionately affected by COVID-19, and really try to help make a difference and get in front of this. With the second organization is called Shield T3, which is being targeted towards everywhere outside of Illinois. We've partnered with 35 different universities across the country and many different businesses and different communities. And we've actually partnered with 7 or 8 different countries now to try to help get our platform out to make as much possible impact as possible. So we're passionately committed to this. I think, again, we want to go global by going hyper-local. I really think there's something about empowering local communities to be able to get in front of this and take control, because people care about making this difference. And I think the more we can tap into that local spirit of let's make it happen, the better. And that's really kind of our approach.
Oh, I love that. And I love how much you've been collaborative, especially with your local public health. Mike, do you have anything you want to share about the match or mismatch therein of capacity and demand and need?
No, I think again, it really comes back to, in part, as I said earlier, the term creative imagination. What are we going to need? What are going to be our long-term issues? I think that, how are we going to respond to the ongoing pandemic well after vaccine is here? And we don't have potentially that many people who take vaccine, along with the potential for a reduced protection and then the potential for waning immunity. I think now is the time to plan for that. Don't assume that just because when vaccine gets here, we're going to suddenly go back to normal. There will never be normal again. It'll be a new normal. And so I think that's where the mismatch can occur if we're not anticipating that will be a time. I don't see us ever leaving COVID-19. I see us only managing it differently as it appears differently in our communities.
Thank you. All right, we have, I'm going to do a quasi lightning round. We have about 4 minutes left, and we didn't get to contact tracing entirely, but there's a question in here about the Apple Google exposure notification system. And since I'm at Google, I'll just say a word, which is that we, like Marty, really felt like we needed to lean in and augment, support, partner with public health where we could to leverage technology to help with contact tracing. It's a part of a bigger system, though, and really where I want to go with this last question for you all is trust, which has been mentioned a few times. Not only trust and partnership, but how the community trusts public health, and just hear y'all's thoughts. Maybe Mike, since you're already on the video, you could start. Then we go Marty and LaQuandra, and just how do you all see that we need to be working on trust with vulnerable populations, partnerships, public health in general, as we go forward to the end of this current stage of the pandemic?
Well, I've been in this business 45 years, and I've always understood that public health was in itself a trust, and it's always has been local. But I think for the first time in my career, I've been challenged as to understand what those two mean anymore. And I think that we have to go back to the drawing board and not assume that just let's do more of what we've been doing to get people to understand what public health is in the trust. And, it can have happened for years and years and years of building up trust can be lost quickly. I think we've had that happen. When it happens at the federal level, it happens at the state level, it happens at the local level. We've seen the rush of public health leaders leave their jobs over really abusive conditions and so forth. I've never seen that happen like I have now. So I think we have to go back to the drawing board and really rethink this, because I agree, trust is critical.
Marty?
Yeah, so along those lines, we think the key thing maybe we've learned is that the community, we need an anchor in the community. They can be that source of trust as well as resources. And so, for example, here our university has kind of been that anchor, but of course there can be many others. A business that employs a large percentage of the population, for example, a church, you know, some type of community organization, or I love Dr. Nesbitt's, you know, firehouse, right? So think about places where people inherently have trust, and find those anchors in the community and allow them to be kind of the bottom-up partners in trying to help create an overall ecosystem for safer living. I think that's something we could really build on.
Thank you. Dr. Nesbitt?
Yes, I would just, you know, Marty just referenced me. I was going to reference him when he talked about hyper local. I would say hyper local, and it's really about finding those credible messengers who can really grasp the concepts and have those conversations in small groups that can bust myths for us, and really get people to take on and understand how participating in these processes are really going to help us have these whole of community responses and recognize that we're all in this together. So when we have the opportunity to explain something to someone who has a question, maybe on the fence, doesn't quite get it, and we have that one-to-one, one-to-four interaction, and all four people walk away with a better understanding and have trust in the process, we have created them as credible messengers, and they can go back and have that 1-to-4 conversation and be force multipliers. And I think the more that we grab that as the way that we're going to make more progress, as opposed to believing that it's going to be that one person all the time who changes the multitude of people, we'll be onto something. So really thinking about this as hyper local, and finding really great embedded credible messengers is going to be key to our success.
That is a beautiful and classic public health philosophical approach to the world. So thank you. I really agree with that. Look, we learned a lot today about models of surveillance, testing, and contact tracing, and ongoing challenges therein for this pandemic, but even into the future. We learned that strong and trusted and supported public health infrastructure is really essential to the response, but it requires partnerships. We also heard it's not only about vaccine, it's not about one solution at all, it's about a set of strategies that come together to tackle outbreaks like COVID and support the public's health every day, and that everything is innovating in real time and in consequential ways, whether that's partnerships, policies, or science. I want to thank APHA and the National Academy for their leadership in bringing all this evolving knowledge to the fore in such a public way, and look forward to continued learning like these. For everyone who registered for today's webinar, you'll receive an invitation to the next webinar. And this has been recorded, and the recording, a transcript, and the slide presentations will be available at covid19conversations.org. Thanks again to our fine panelists, to the APHA and NAM, and to all of you for joining us today. Please stay safe and healthy, wash your hands, wear a mask, keep a distance. Take care.